Hello, good morning, good afternoon, and good evening to all our speakers, shares, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Bulgaria, Dr. Thomas Piriev. Dr. Thomas Piriev is currently a neurosurgeon at the Neurosurgery Clinic, Akibadem City Clinic, Tokuda Hospital, Sofia, Bulgaria. During his residency training, he has numerous international fellowships and he has completed the ENS training courses, receiving the Brackman Prize. His main interests are neuroanatomy, neuro-oncology, skull-base and neurovascular surgery. His research in 3D visualization techniques, 3D modeling and 3D printing and their applications in neurosurgery for preoperative planning, education and training. He has published extensively about white matter dissection in various peer-reviewed journals and book chapters. He is the founding member of the famous 3D Atlas of Neurological Surgery, and we are extremely honored to have him today at our webinars. And today he'll be talking about 3D neuroanatomy, preoperative planning, and education. The speaker for the second session of today is our honorable guest from China, Professor Xiao Baoshi. Dr. Baoshi has obtained his bachelor and master degree in clinical medicine at the Capital Medical University. He then joined the Department of Neurosurgery at the Beijing Tiantan Hospital, and he was named as the attending doctor in December 2017. He was a postdoctoral fellow at the Jiguang Wang's lab in 2019, and he is the associate director of number 5 Neuro-Oncological Neurosurgical Ward at the Beijing Tiantan Hospital. His major interests are scientific researchers and personalized clinical treatments for patients with the recurrent glioma. He focuses on multi-omics based research on fusion gene induced glioma progression. We are extremely honored to have him today at our webinars, and today we'll be talking about efficacy and safety of Vbereltinib in IDH mutant high-grade gliomas. The chair of the first session of today's webinar is our honored guest from Spain, Professor Pablo Gonzalez Lopez. Professor Pablo is the professor of neuroanatomy at the Miguel Hernandez University, Alicante, Spain. His practice is focused on skull base and neuro-oncology, and he has specific interest in neurosurgical education and is among the Spanish delegates for EANS and member of the WFNS. He is a co-director of the 3D neuroanatomy project and is acclaimed researcher with several publications to his credit. He has gained his knowledge in neurosurgery through several fellowships, working with giants like Professor Lawton, Professor Oliveira, Professor Fukushima, Professor Hannes Niami, and Professor Ture. And we are extremely grateful and honored to have him today to chair the session of Prof. Thomas Parrier. The chair for the second session of today is our honorable guest from the USA, Professor Venia Linda B. Dr. Linda B is an Associate Fellowship Director, Associate Program Director, and Co-Director, Scientific Advisory Committee at the Brigham and Women's Hospital, Boston, Massachusetts. She is also the co-course director, Cerebrovascular Skull Base Annual Symposium at the Department of Neurosurgery, Brigham and Women's Hospital. She is a neurosurgeon with deep interest in patients with benign and malignant brain tumors, and she has focused on mechanism underlying glioma invasion and tumor microenvironment. She had received several awards for her outstanding contributions to neurosurgery, especially the very recent Presidential Fellow Award of the Brigham and Women's Hospital. We are extremely grateful and honored to have her today to chair the session of Professor Bao Zhaoxi. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I'd like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Ben from China is our co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Pablo Gonzalez.
Yeah, Ben, everyone, it's a big pleasure, as always, to be here, and especially today, and I'm privileged to introduce Professor Thomas Piriev. And I say privilege because I was thrilled and very lucky to attend his last lecture in Sofia, Bulgaria a few weeks back, talking about a topic that I really love, which is combining education, training, neuroanatomy, new technologies for the best result of skull-based surgery and white matter surgery. So I think this is the peak of our education purposes, and I'm very, very happy to introduce him. And I cannot add too many things to what Raj already did, but I must confess that I have been looking this morning. I have been Googling you, Thomas, and I must say that his amount of publications in PubMed are fantastic. So I really recommend you to go through them. And also his Atlas CD, Atlas of Neurological Surgery, is a piece of art. So please Google it and have a look. You will really enjoy the tremendous effort he is doing on neurosurgical education. And with that, again, thank you for having me here. I really looking forward to listen to his talk about 3D neuroanatomy in surgery, preoperative planning, and education. Thank you so much.
Thank you, Paulo. Thank you, Professor Kuti. It's really, really a great honor for me to be here, and thank you for the really kind introduction. So thank you again for the very kind invitation. Today I'm going to speak about preoperative planning and education, and I have nothing to disclose except that the 3D Atlas of Neurological Surgery platform was initiated by the ENS Research Fund Award 2 years ago. So I divided the talk in two parts. First will be the preoperative planning and the way that we used to do it and the way that we do it now. And the second part is how all this knowledge of preoperative planning using 3D platforms has helped me to start the 3D modeling and photogrammetry part of the platform that we have created, the 3D Atlas of Neurological Surgery, and moreover how we use this for education. So one of the biggest challenges that we face, especially when we start residency in neurosurgery, is how to properly plan the craniotomies. This is extremely hard, especially if we have to measure from non-anatomical landmarks and we want to do minimally invasive craniotomy and to develop what Rotten and many others have implied as a see-through X-ray vision. This is very hard, especially if we rotate, if we have to see through the rotated perspective of the operative craniotomy, especially if we speak about aneurysm surgery and how the dome of aneurysm looks and where it looks and when it points out, and if we speak about white matter and where did all these important tracks pass. So there are many options nowadays which use advanced preoperative planning and navigation programs and neuronavigation systems now also with in virtual reality and mixed reality. But we all know that these are quite expensive type of equipment and are not readily available. So in our practice, especially from 2014, 2015, 2019, we didn't have any neuronavigation in our system, in our hospital. So we used to plan all our cases using open source software, which basically we use these three types of software: Horus, Slicer, and Blender. And there are quite a lot of things that you can do with open access software. You can simulate the patient positioning. You can do a window craniotomies, which simulate the craniotomy. You can visualize where the lesion is located. You can do a skull stripping and present the brain as anatomical specimen, so you can see the superficial venous anatomy. You can see where the lesion is located. You can properly plan the craniotomy, and you can be mentally prepared for the surgery. So if we have a lesion that is located just in front of the precenter gyrus, and we mark and we locate the center of the lesion from non-anatomical landmarks like the glabella or the mid-pupillary line. So we can simulate the patient positioning, we can simulate the craniotomy, we can simulate also the skin incision. And again, this mental preparation, which is quite important when we envision where the craniotomy should look like and where the lesion have to be located. So when we see that operatively, we see the same landmarks like these Y-shaped venous structures within the dura. We know that we are in the center of that the lesion is in the center of our craniotomy. So we used to do that using these are the tools from the Horus software. So we measure using the open polygon tool. We measure where the location the tumor is from non-anatomical landmarks. After that, we used to place 3D markers on the top of the skin that show the projection of the lesion and show also the trajectory of our approach. After that, we can simulate the skin incision, or we can play with different skin incision, and we can find the most appropriate one for this particular type of lesion. After that, the skull stripping method, which was described in a very elegant paper from Harput, and of course Pablo Gonzalez. It was really so it's a little bit hard at the beginning, but when you start to get used to it, it's not that difficult. So after that, what we do is you can change the level of the parenchyma, and you can see the lesion and associated cortical anatomy. And by this way you can have this mental preparation that we used to speak about. So these are intraoperative correlation from preoperative planning and intraoperative data, intraoperative images. We used to this is the cortical mapping. We had here a response from the hand, so we knew that the approach should be behind this venous this bridging vein in order to stay safe. Another option is another thing that I wanted to speak about are the meningiomas, which are highly vascularized lesions. And using simple CT angiography, you can actually do a quite good preoperative planning to see exactly where the meningioma is and how the vessels are displaced. And if you use multimodality planning using also MRI and CT angiography, you can actually have a real good mental image of what the steps of the approach must be in order to execute to do safe surgery. And this is another example of frontal-basal craniotomy, and we see of the tumor, which is a frontal base meningioma, how it displaces the vessels, and how the approach gives us the best trajectory to the tumor. So we used to describe this in an open access paper some years ago. Nowadays, we do the same steps, but we use for VR planning using slicer software. Again, only open access software and softwares that are readily available. So this is in slicer software. We segment the vessels. We also segment the brain. We isolate only the brain and the lesion. And this is how actually after that we place the model in Blender software, where we decimate, which makes it a little less voluminous in terms of megabytes in order to be uploaded to a VR headset. We use the software called Gravity Sketch, which is also, it's not open access, but it's free to use. So, and this is how it looks like in a VR. So you can immersively simulate the patient positioning, again, the skin incision, all the steps that are necessary to perform surgery. Again, this mental preparation, it's extremely important, especially in the beginning of one's career. So all this knowledge that was gained through the years with using these software platforms. After that, we with 3D modeling and segmentation. Some years ago, with our colleagues, we decided to implement it and to create an open access platform that can be used for education and for training. So we all know that there are many challenges nowadays with anatomical teaching, which are difficulty with specimens. There are some ethical issues, and unfortunately, some of the approaches, some of the teaching in anatomy is dedicated only in expensive courses. For example, I also teach neuroanatomy to medical students once a week, and we have in Bulgaria, fortunately, there are no anatomical specimens. So we need to rely mostly on 3D data and what we have in the atlas. There are many options now for 3D atlases. So one are this is a very beautiful atlas that I recommend to everyone, that I also use in my teaching. And this is very informative, but unfortunately, these are the 3D segmented data that are made from 3D model data that are made from professional medical artists, which sometimes do not correspond fully to reality, which in terms of textures, and this is one of our dissections of the back muscles. So what we did as in order to make photorealistic dissections, and we used technology called photogrammetry, which is a process of surface scanning that uses standardized photographic equipment, and it's basically a way to create 3D photorealistic models from simple two-dimensional images. So this is the setup that we use in Düsseldorf with two white diffuse LED screens in order to have proper light, which is the most important the prerequisite to have really sharp sharp textures and delineation of different anatomical structures. And the process includes, first we take numerous images from many different angles of the specimens, between 120 to 180, sometimes even 200 if it's very detailed dissection. So what the software does is, first it estimates where the image were taken from. After that, it builds the point cloud, which is different dots in a 3D space that matches where the photographs from different directions were taken. And after that, all these dots are triangulated and primary 3D mesh is built. And after that, the software places the textures on top of this 3D mesh. At the end, what we have is this 3D photorealistic image that we use only basic 3D modeling in Blender software to remove all the necessary parts of the 3D model. And after that, when we place the 3D model in a 3D environment with all the lights, with all the filters, and most importantly with annotations, we end up with this result. A 3D model that you can rotate, pan, and zoom and see from every different direction. And you can rotate it from an operative perspective, so you can have a much better idea just compared to seeing magnified anatomy from 2D atlases. So the anatomical dissections were done in several universities, in Sofia University, in Heinrich University in Düsseldorf, in Copenhagen University in Panum Institute, and the Laboratory of Neuroanatomy in Salerno. So from 2021 till now, we have more than 600 3D models, which include neuroanatomy, complex neurosurgical approaches, peripheral nerve surgery, and DICOM-based simulations, which we decided to be available as open access website that is and will be non-profit, which is the 3D Atlas of Neurological Surgery. So this is after the last update that I'm going to speak about in a moment. What we have in the anatomy section, which are skull bone anatomy, craniometric and sulcal key points, which are based on the work of Professor Ribas and also many others, which is extremely important for preoperative planning. Brain anatomy, including fiber tract dissection, cavernous sinus, skull-base dissection, especially this part, which is skull-base 360, which I'll speak about in a moment. There are also spine dissections and peripheral nerve anatomy. So this is how the individual 3D models look like. You can load several 3D models on one page. We wanted to keep the design simple as possible without many words. And each 3D model is annotated. And when you click on the annotation, the camera turns automatically to it. You can see them full screen. You can remove the annotations also. And we also have stepwise 3D approaches, which include basic and advanced cranial approaches, spine approaches, which will work more next year, and also peripheral nerve approaches. So this is the section of the complex spine approaches, including petrosectomies and orbitozygomatic approach, far lateral approach, etc. Now there are more, and this year we'll do also petrosal bone approaches probably next month. So there will be another big update in the beginning of next year. And this is what a retrolabyrinthine approach look like. These are the semicircular canals and the course of the facial nerve. So again, another example is the orbitozygomatic approach and the sequential cuts that needs to be made in order to have the one-piece orbitozygomatic approach. And this is at the end, the extradural exposure of the cavernous sinus combined with anterior petrosectomy. And anterior clinoid process removal, we see the proximal and distal dural rings, the third, the fourth nerve, V1, V2, V3, Gasserian ganglion, and here the cochlear angle. Here is the facial nerve, and this is the pons here. So I wanted to make an example because all the dissections that are within the atlas are layered anatomy, which means that you can see from the most superficial to most deep layer when you follow each category. So I think the good example of this would be our first project that we did actually was the anatomy of the vertebral artery and especially the V2 and V3 segments of the artery. So I wanted to describe this anatomy for you and some of the safe techniques to expose the vertebral artery around C2 and the muscular anatomy of the posterior neck muscles and the fascial anatomy there, which are quite important for when we do far lateral approaches and the approaches to the vertebral artery C1, C2 junction and when we place screws in C1, C2. So we start with the most superficial layer. What we see here is the trapezius muscle, this is the splenius muscle, and this is the sternocleidomastoid muscle. Here we see the occipital artery, which pierces the fascia around the superior nuchal line. Here we see the linea nuchae, which is the avascular plane, the most safe plane for avascular dissection when we do a midline suboccipital approach. Here the trapezius muscle is reflected, so what we see below is the splenius muscle, which attaches to the mastoid. This is the longissimus. This is the longissimus muscle, and here what we see is the accessory nerve. So when we see that how actually superficial is this nerve just below the trapezius, so probably approaches within this area, we have to be very careful with it. Here we see the greater occipital nerve and again the occipital artery. Okay. We remove the splenius muscle and we see the semispinalis capitis. We left the linea nuchae intact in order to show that this is a deep structure that goes from the superficial to more deep to the tip of the spinous process and the inion. Here we see the longissimus muscle and the artery in the second segment, the occipital artery, that can be below or above the longissimus muscle. Which is important if we consider it as a donor vessel for extra intracranial bypasses. So here, from the other side, again, the longissimus, levator scapula, and the accessory nerve. This is the deepest part of the dissection. So the semispinalis capitis is reflected, and we see the semispinalis cervicis muscle which attaches to C2. This is C1, and these are the muscles of the occipital triangle, superior oblique, inferior oblique, rectus capitis posterior major, and this rectus capitis posterior minor muscle. So we see the beauty of this anatomy and what actually such a 3D model can give us and how this anatomy can be rotated in order to better understand the structures of within this region. What is important here is how to make surgery around C1 and C2 safe and bloodless. And knowing this anatomy well, we can do and keeping simple principles. So when we detach the muscles from C2 and we reflect them posteriorly, there is always this the vessels, they are enveloped in fat tissue and this loose areolar tissue. If we keep the dissection close to the occipital muscles and not close to the C1 posterior arch, and we do here the coagulation, we can safely detach the suboccipital muscles from C1, and we can develop this plane without any risk for injuring the horizontal portion of the vertebral artery. So if we do that, the vertebral artery remained enclosed within the fat pad and the venous plexus here. Another important point is if we want to mobilize the vertebral artery. This I know this from the great Bernard George, who I had the privilege to see operating in his last surgeries. He always used to dissect to cut the periosteum on the C1 posterior arch and do a subperiosteal dissection. By this way, it allowed him to lift the artery with the venous plexus and keep the dissection bloodless as bloodless as possible. So it was really a beautiful way to look at his surgery, which are more than looked like anatomical dissection, not actual surgery, especially when he did this approach or the anterolateral approach. So here we removed the fat pad in order to show the vertical and horizontal portion of the vertebral artery, and this is the C2 nerve root. Here we took some part of the posterior arch of C1 in order to show C1 C2 junction, and these are the entry point of C1 screws, and here are for the C2 screws. So this is a good way, if we look at such 3D models, to prepare for such complex and sometimes, unfortunately, dangerous surgery within this area. This is the final 3D model from this layered anatomical dissection. So we see the transverse and sigmoid sinuses, the emissary vein, and this is the C0, C1 joint, and the vertebral artery, how it pierces the dura here. And this actually here. It's we were lucky to have extradural origin of pica, which according to studies can be between 15 and 10 to 15%, and we have to be very careful with when we do dissections here. So each year we do 1 or 2 projects, anatomical projects. Last year was this one, which were the photorealistic 3-dimensional neurosurgical anatomy of cerebral arteries, which was recently published in Operative Neurosurgery, which showed the detailed anatomy of the arteries, especially here that we see even the perforating artery we were able to show well. This year, what we did, we had a big update of our database. We did 2 projects. One was in Copenhagen with Ko Fugelholm, Mike Fox, and Markus Krugager, which involved the photorealistic dissections of brachial plexus and also approaches to peripheral nerve. So we did photorealistic atlas of peripheral nerve approaches, and the next one is our skull base and brain white matter dissections, which was done in the Institute of Anatomy of Heinrich University with Jan Cornelius and Michael Wollenbücker. So actually, this was the first fellowship that we did. We had 2 fellows from the Italian Society of Anatomical sections of the Italian Society of Neurosurgery, Francesco and Daniele, which did really an amazing job. And I'm going to show you now about what we did with the skull-based dissections. We decided to do a 360 type of skull-based dissections, which involved dissections from lateral to medial and from medial to lateral part, and gradually combining the two dissections. So this was the most superficial, and this is actually the most deep part of the dissection. So here we see the carotid artery. So we see also here the cavernous sinus and the trigeminal nerve, and was reflected in order to see the segments of the carotid artery within the cavernous sinus. We see the 3rd, the 4th, V1, V2, and V3 nerves, and we can see them from lateral perspective, and we can see them also from medial sphenoid sinus perspective is also the orbit, and the skull base from cerebropontine angle point of view, also from a transmastoid point of view. So you can follow all the structures from medial to lateral from their entire course. And this is also layered type of anatomical dissections, from more superficial structures to more deep structures. And the idea again was to gain this layered type of 3D understanding of this really complex anatomy. So I remember this is the facial nerve, and that Francesco, one of the fellows, spent one day to dissect all the small branches of the facial nerve here in the previous dissection. And here, so he spent the whole day dissecting each of these branches. At the end, when we started to go deeper and deeper, we started to cut off these branches. He was quite devastated that we had to do like this work. Okay, so what are the applications, at least from our perspective of this in educational point of view of the 3D photorealistic anatomy? So we use them as a teaching tool to show the different perspective of anatomy. I'm going to speak about at least what I envision for that. Stereoscopic 3D anatomy, augmented and mixed reality, also a type of teaching. So this is from the Copenhagen Skull Base course, and this is they use the 3D atlas to show the different steps of the approaches and what the anatomy should look like. But especially in our courses here in Bulgaria, and this was a very nice event that we did in St. Gallen last year. So each of these models is done from many images, 120 to 200 images, as I said from the beginning. So you have approximately 200 perspectives that you can show each of this anatomy, and you can turn this 3D model in the perspective that you want to particularly show to the residents, to the medical students, to the fellows, and the perspective that you want. So with the simple like annotation tool, you can actually make really good educational event just from one or even two 3D models. Stereoscopic 3D anatomy, which was really a big thing many years ago when we had the privilege to watch the Rotten lectures and many others. It was really nice and instructive at that time. Now it's a little bit more difficult to organize such these events because of the stereo 3D equipment is not that available, but we still can do that. We do this in our practice here. And in difference to that time, now with the 3D technology, we can do not only single images, stereoscopic images, but we can do also stereoscopic 3D videos, which can be quite more informative, and we can make the whole 3D lectures like a movie, not like still images. Augmented reality teaching, this is another important point. So each of these 3D models can be viewed without any additional app needed, just directly from the website that can be projected with any modern 3D phone, with any modern smartphone. So what we do here is an example of this is the real anatomical dissection, and this is the 3D model projected next to it. So the photorealism is quite nice. This is how it looks like viewed from the outside. And what we use it here with our residents, since we project these 3D models next to a 3D printed model, in this case, a model for pedicle screw fixation. And actually they enjoy it quite a lot because they can try even to overlay the data. And also with mixed reality headset, this is quite instructive. Virtual reality. This is the other possibility that we use to teach residents. Here is also we loaded the 3D model in Gravity Sketch, but you can do it with other open source software like OpenBrush, or there are many softwares now available for virtual reality. So here we ask the students to draw using the draw tools, and by this way, it is much more easy to actually for them to understand the course of the different vessels. And we do also seminars in VR by this way. Another thing that I wanted to speak about is intraoperative photogrammetry. So each of the modern cameras and each of the modern microscopes has each of the modern microscopes, endoscopes, and exoscopes has really good cameras. So if they have a camera, you can produce a 3D model by it. There are different ways to do this. So for superficial scanning, you have to scan it like in this dome-shaped area. But if it's for deep scanning, you have to scan it like a cone. I mean, you have to turn around the microscope like that in order to scan each part. You can do it with the photos, but you can do it with the video. And these are some examples of screenshots from intraoperative 3D models. So with using the intraoperative microscope, and it takes approximately 1 minute to do such 3D model. And the best thing is that you don't need to take out the microscope and use a camera to bring some non-sterile camera in order to take images. This can be done with limited interruption of the surgery itself, and can be quite fast. But at the end, what you get for superficial scanning, it's quite easy. For deep scanning, it's a little bit more difficult. But this is frontal-lateral approach or lateral supraorbital approach, and you can rotate it from 360 degrees, and this is a great way to show the resonance what you can get with such operative perspective. So and they often ask us when we do a supraorbital approach, okay, but where is the Sylvian fissure? And now when we have these 3D models, we can rotate the 3D model and we can show them actually that the Sylvian fissure, you have to open it from top, from anterior to posterior, but looking from top, compared to the pterional approach when you go frontally, but you have this lateral perspective, and this is where the Sylvian fissure is. And here, this is where the Sylvian fissure is. So this is what actually I think will be much more valuable when we start to have these intraoperative 3D models, because these are from real surgical scenarios data, and will be much more valuable to residents. This, of course, you can load each of these 3D models in virtual reality, and you can place, of course, these 3D models next to real dissections. So in order to have the dedicated or didactic type of teaching experience and learning experience, this is a pterional approach. For ophthalmic aneurysms, this is the anterior clinoid has been removed, and this is what you can get as approach. This is why we chose this approach for this type of aneurysm, not supraorbital approach, because from here you have this inferior view, and when you direct corridor to the aneurysm itself. This is the optic nerve. This is the internal carotid artery, and just by lifting or gently retracting the frontal lobe, you can have really beautiful access to this type of aneurysm. So again, I would like to say that this project, the 3D Atlas of Neurological Surgery, was initiated by the ACNS Research Fund, and is supported by the European Association of Neurological Societies, and all the partners that were involved in the creation of this project, which is the Heinrich Heine University, also the Copenhagen Neurosurgery, and of course with the team behind it. These are people, as you can see, from Bulgaria. These are people from Denmark, and these are people from Italy. And these are the last two fellows from the Italian Society of Neurosurgery. So thank you for your attention. I hope that I kept the time, and I'll be really happy to reply to any questions that you have. Thank you.
Hi, Thomas.
Yes.
That was absolutely outstanding. I must say that I have to congratulate you. I thank you, especially for sharing this with the community. Whenever I see someone who is giving a tremendous effort of his time, his research, his spare time, his efforts, and then sharing his results with everyone, it's something that we must really congratulate and really appreciate. And this is what I want to do, first of all. So thank you for that.
Thank you. Really appreciate that. Thank you. It's an effort from, as you saw, a great team, but we all share the same perspective that knowledge should be open to everyone. So this is what we do, and we try to do our best.
I know that, and I also know that what you are doing and the whole team are doing is a lot of time, a lot of effort. I have done it myself with some colleagues, my residents, so I know how much it takes to create such an outstanding 3D reconstruction. It's not only going with your camera there and sharing it on the website. It's a lot of study on papers, on anatomy, going to the lab, spending hours and hours, giving your best to get the best dissection, and then you just acquire it and share it. So I know what you're doing, and that's absolutely brilliant. And I cannot see any live question for the time being. Well, I can see comments. Just thanking you for these fantastic explanations, and I have many questions. I must call you after the the webinar to ask you about many technical questions. But first thing, it's a difficult and probably a lazy question from myself, but recently we have all these technologies, and we have the lab, we have the cadavers, we have beautiful drills, microscopes, fantastic cameras, 3D reconstructions, VR, AR. We have probably too many things, too many sources of information. I do believe all of them are really important, but what I'm trying to figure out in my mind is to create an ecosystem in which we can kind of order all these things and create let's say a program or a schedule for our trainings. And in your mind, I know it's very challenging question. I don't know have the answer. That's why I'm asking you. How do you see proper training of a junior neurosurgical resident on anatomy, on neuroanatomy? Which tools do you believe are the most important? How do you think about that?
Thank you for this question. So yes, it's a challenging question because it involves a year's type of program, but of course anatomical dissections are quite important even nowadays with all these new technologies that we have and everything that we see, like virtual reality and augmented reality. These ones, even also our atlas that we did, cannot replace what you get in the lab. But it can be a good adjunct. So I think that first what we do with our residents here is that first we try to prepare them with the perspectives that they need to have for surgery, because we all know that in the atlases the images that we usually see are not the perspective or not the angle that we usually know from surgery. So we start with like approach, like the Triono approach, and we rotate the 3D models in the perspective that they have to see, and step by step, like layer dissections. We also use 3D printing, but fortunately for now, quite basic, like I showed you for screws. And when people are ready with the anatomical knowledge, after that, of course, at that time, I think anatomical dissections will be quite important, because now we have very limited time for anatomical dissections, especially in our parts of the world. You cannot just go in the anatomy and make a dissection. You need a project, you need some very limited time. And in order to use this time as effective as possible, you need to be prepared. And I really hope that this type of 3D data that we have will help for the preparation of people to use this time, this limited time that they have in this section. Again, I say in our part of the world, to understand better the anatomy, the approaches, and the related anatomy. So this is at least what I think. So, of course, with VR, you can have this immersive experience. You can rotate the 3D model, and but of course, this also help for the preparation to go to the lab, and so good theoretical knowledge, and after that, good hands-on knowledge is what I believe will make us better.
Thank you, Thomas. I do believe so. Also, indeed, I with time I consider that cadaveric dissections and cadavers are priceless, and we really need to squeeze a cadaver. So whenever I go to a course and in 2-3 days, we just end up doing 10 approaches and just forgetting what we did, I think that's a waste of resources. So I believe that these new technologies can help us to be prepared before we go to the lab, and to be really prepared. And what you said about Alberto was your ex-fellow, Alberto from Italy, or Francesco?
Also, Francesco and Alberto Piazza.
I don't know. You were talking about he spent one day doing the dissection of the branches of the facial nerve.
He was devastated.
So that's an important point. That's an important point. He will never forget that in his life. He has now a wide experience on these branches. That's what I believe. Spending hours and hours in the lab and squeezing as much as possible the cadavers is what we have to do. And these new technologies, I think they can help us to really take the more profit of our time in the lab possible. So checking again, no other questions. And if you allow me, I have a, sorry, Raja.
There is one raised hand from Ben.
I didn't.
Ben, sorry.
Yes. Okay. Can allow me for a very short comments. So again, and congratulations to Tom, and I still remember the time at Sophia that I saw you applied the technology to the Apple Vision Pro, and that's awesome. That's fantastic. So I besides congratulations, I have a questions. Very short question. Like now, there are some authors who apply the AR and VR technology during the operations. So I would like to ask about your opinion on using to project it on the patients, and usually I saw you have some intraoperative the photogrammetry, and usually how long you takes to make them, and do you think you will apply this kind of technology to the VR or AR to project to the real patients? Thank you.
Thank you, Ben, for the question. So first, in order to do an intraoperative 3D model, actually it's quite fast. You can do it with photos, but you can do it also with video, which for the sake of time for the operation, and we cannot lose too much time, is quite precious there. You need 1 to maximum 2 minutes video. So 1 minute video it's enough, but you have to scan the whole operative the area, and after that, with a decent powerful computer, you can generate the 3D model in like 2 minutes. So, and between 1.5 minutes to 3 minutes. So it's quite fast to generate these 3D models. This is one of the things. And second, if you want to project something on the patient's head, for now, I think, at least from my knowledge, it's quite difficult for one reason. It's still difficult to match exactly the anatomy and the perspective the rotation with the segmented 3D data of the patient. And of course, there are quite a lot of advances in this, but still it's quite difficult, and people do it manually. They take the 3D model, and in mixed reality, they just overlay it on the patient head using known anatomical markers. But when you cover the patient, it's quite difficult. So I think this is one of the biggest challenges now, but this technology advances quite fast. And we saw even for the last 3 years, the headsets from very basic ones, we have now the Apple Vision Pro with a tremendous amount of possibilities there. And also from the other competitors with the Microsoft, etc. So I'm sure that in the few years, we'll see beautiful things there. And useful. The most important word is useful, actually.
Thank you.
Thank you so much.
Indeed, I was ready to ask exactly the same question than Ben. And another question I have, Thomas, is about, it's a technical one. When you are doing photogrammetry, I always experience problems with the lights. And I saw you have 2 fantastic panels of white light. But even that, sometimes my movements or the camera, wherever I decided to place the camera, I create shadows that somehow obscure or annoy the final result. Do you have any clue about that, how we can solve that problem?
Ask you, what type of camera do you use?
Well, it depends. Sometimes I even use my smartphone, or we have a Canon DC50. But most of the times now we are using the smartphone, indeed.
Yep. Yeah, this is the small trick. So you have, if you use a smartphone, it's small, so you don't obscure the operative field. You can do it with either with we described that we can do it either with very expensive like Mark II Canon type of camera with big lenses, etc., which create beautiful at the end, a very detailed 3D model, very big in megabytes. But if you want to have this without the shadow effect, I think even the newest type of smartphones can do quite decent work. And the other way is if you fix the specimen in one place, and you on a rotating table, you rotate the specimen and you just shoot from only one direction. These are the 2 ways. You either go around the specimen and take pictures by yourself. It depends of what you want to get at the end result, or you either rotate the specimen on a table. These are the 2 ways. But the small size of the smartphone is this what will prevent the shadow effect.
Thank you, Thomas. Thank you so much.
Welcome.
So, Raja?
Yeah, so I think we can call it a day. Fine. So, first of all, let me thank Professor Thomas Sparier for this excellent demonstration of what things can be used for preoperative planning. I believe this should be a workshop in itself for the juniors in the coming. I think IANA can take this lead and organize such pre-op planning workshops in different venues. So thank you very much, and thanks to Prof. Pablo for taking out his time. We're extremely grateful to you both. Now our Honorable Chair, Professor Vinelinda B, has joined us from the USA. Over to you for the second session. Thank you very much.
Thank you, Professor Raja. And that was a spectacular talk, really a masterclass and very useful tools for all. So I have the pleasure of introducing Professor Bao Zhao Shi from Tiantan Hospital in China for his talk on efficacy and safety of Vbereltinib in IDH mutant high-grade gliomas. I think that as many of us have experienced, the limits of microsurgery in these aggressive high-grade gliomas can sometimes be frustrating when the tumor recurrence occurs. And thinking about not only local cytoreduction, but the microscopic infiltration and how to deal with recurrences is really always on the mind of the neuro-oncological surgeon. So quite keen to hear your research and advances on this.
Thank you, Vanya. And thank you, Raja, and thank you, Professor Xu Bin's invitation. And I will share my screen. My name is Zhao Shibao from Beijing Tiannan Hospital, Capital Medical University. And it's my great honor to report here. Today, I will share a topic about the efficacy and the safety of the Vbereltinib in previously treated IDH mutant high-grade glioma patients with PDPRZ1 MET fusion. This clinical trial, randomized multicenter open-label phase 2 and 3 trial, which we call it FUGEN trial. The FUGEN study was a randomized multicenter open-label phase 2 and 3 clinical trial. In this trial, a total of 84 patients were enrolled and randomized 1-to-1 to Vbereltinib group or control group. The median OS in the Vbereltinib was 6.31 months, while in the control group it was 3.38 months. The HR for OS was 0.52. The FUGEN study sheds light on the novel therapeutic pathway in the landscape of IDH mutant high-grade glioma. First, I want to introduce some backgrounds of glioma. Glioma is the leading cause of CNS tumor-related death, are notorious for their progression from low-grade to high-grade malignancies. Its diagnosis is based on the histological classification of the resected tumor and the molecular profiling by DNA-seq methylation profiling, in situ hybridization, and etc. Glioma is the most frequent brain tumor with significant heterogeneity and lethality in adults. Medical data generally include electronic medical records, information on histopathology, and images, but it's difficult to reflect the molecular information of tumors. So multi-omics data integration is required for precision medicine. Since 2004, under the guidance of Professor Tao Jiang and the following international standards, we have selectively targeted the establishment of a large-scale multicenter glioma sample database from the Chinese population. In 2012, we established the Chinese Glioma Genome Atlas, which is short for CGGA website, which will provide massive amounts of data for the basic and clinical research of gliomas. The aims of CGGA is integrating data of RNA sequencing, DNA sequencing, images, and clinical data from Chinese glioma patients to provide multi-omics glioma resource of Chinese patients, identify novel glioma-associated alterations, develop imaging genomics of glioma, explore glioma immune microenvironment, and develop artificial intelligence for glioma diagnosis and intervention. So far, more than 500 SCI-cited papers have been published, and more than 20 projects have been applied by using this database. The big data represented on the CGGA platform includes the clinical information, for example, the basic and follow-ups data, the molecular pathology information, and the high throughput data, for example, the sequencing and the microarray data. So far, we have collected about 12,000 clinical samples, including more than 2,500 with complete follow-up, 1,000 with MRI images, and more than 2,000 with WGS or WES or RNA sequencing results. We have selectively collected 255 recurrent and secondary glioma samples in CGGA, including 146 with paired initial tumor samples. We have the low-grade and the same samples, progression samples. Compared with glioma data from TCGA, the major group of samples is primary gliomas. Using the CGGA database, we have identified a series of biomarkers for diagnosis, prognosis, and prediction for drug response. The trial I will introduce today is based on our finding of PTPRZ1 and MET fusion gene. So first, I will introduce the research progress of PTPRZ1 and MET, which we call it ZM fusion gene. In 2004, the CGGA database was prepared to be established by our academician Chao Jiang and the follow-up was started. Full platform sequencing of the second generation genome of whole-grade gliomas began in 2021. Then we obtained the Vbereltinib's exclusive license patent in China in 2012 and applied for an investigational new drug to CFDA in 2013. In 2014, CM fusion genes were found to be mainly present in patients with secondary glioblastoma. We published this paper on genome research. Then we constructed the patient-derived cell line and animal model transfected with CM fusion gene in 2015. The patent for glioma indication and the clinical research approval was obtained in 2015. In 2016, the abnormal expression of MET was identified with temozolomide resistance, and the phase 1 clinical trial of glioma was launched. In 2017, CM fusion gene promotes malignant phenotype and temozolomide resistance through exome secretion. We published this paper on oncogene. Then in 2018, the phase 1 clinical trial of glioma completed, and the progression mechanisms of glioma was driven by CM fusion and MET exon 14 skipping, and the results of the phase 1 clinical trial was published on Cell. Then we launched the phase 2 and 3 clinical trial. In addition to the identification of CM fusion in glioma samples, we also identified the recurrent CM fusion and high occurrence rates of MET exon 14 skipping in brain metastasis in 2022. And the phase 2 and 3 clinical trial was completed in 2023. So what's CM fusion gene? We have identified the novel recurrence fusion gene in glioma. The 4 fusion transcripts involved 4 different breakpoints within the PTPRZ1 coding sequence, whereas the breakpoints in the MET gene were exactly the same. As we all know, chromosome rearrangement and subsequently followed by translocation induced gene fusion, which is defined by hybrid genes from 2 previous separated genes. Gene fusion, which induced by extrinsic and intrinsic factors, can occur as a result of translocation, interstitial deletion, or chromosome inversion. Since the Philadelphia chromosome was discovered in chronic myeloid leukemia in 1960, studies over the past 6 decades have identified fusion genes in various of other neoplasias and through many different approaches. It was not until the introduction of chromosome binding techniques in 1970s and the malignant cells could be announced in unprecedented detail. With these new techniques, previously undetectable subtle chromosome rearrangements could be detectable. Technological development in the 1990s and the 2000s of high throughput methods for genetic analysis, such as microarray and next generation sequencing for gene expression and copy number profiling, provided new approaches to make gene fusion detection. In 1962, Peter Novell and D. Hartford found a minute chromosome replacing one of the 4 smallest autosomes of chronic granulocytic leukemia cultured from peripheral blood. The aberrant chromosome rearrangement was then named as Philadelphia chromosome. The fusion protein produced by BCR and ABL fusion is an abnormal tyrosine kinase that drives the development of myeloid leukemia with successful developing of imatinib against this fusion protein for healing CML. Chromosome rearrangement that leads to oncogenic kinase activation are observed with less frequency in solid tumor, owing to the hard sample collection and the technological limitations. The The TMPRSS2 and ERG fusion was the first time that specific gene fusions were found to characterize a major subset of a common epithelial malignancy. This slide shows the number of gene fusions involved in major neoplasia subtypes. We can find there are few recurring gene fusions events in central nervous system. In high-grade pediatric gliomas, NTRK gene fusion was identified as an oncogene to active MAP-AKT pathway. QKI is a tumor suppressor gene. Scientists reported that MYB-QKI fusions suppress expression of QKI, leading to malignancy in low-grade midline pediatric gliomas. A similar fusion events which associated with FGFR3 gene was identified in adult glioma samples by RNA sequencing. In this fused mRNA, exon 16 of FGFR3 fused to exon 8 of TAC3. Professor Wei Zhang's team showed FGFR3 and TAC3 fusion escapes miR99A regulation in GBM, inducing overexpression of FGFR, leading to glioma malignancy. Then Adonio group found the correlation between FGFR3 and TAC3 fusion and metabolism of mitochondria, indicating a novel mechanism of fusion-induced pathway activation. As I have mentioned above, we have identified a novel recurrent fusion gene in glioma, PTPR01 and MET fusion from whole-grade gliomas. The ZM fusion occurs around 15% of patients with IDH mutant astrocytoma WHO grade 4. Survival analysis demonstrated that IDH mutant astrocytoma WHO grade 4 patients with ZM fusion had poorer OS than those without this fusion. Median OS in patients with ZM fusion was only 4.2 months, even worse than the OS of 5 months in the recurrent GBM. Next, Kim Mission Jiang's team developed a highly selective ATP-competitive small molecular MET inhibitor, PLB1001, which was also called Vbereltinib. In vitro analysis showed that Vbereltinib had higher apparent permeability and a lower efflux rate than other MET inhibitors, for example, crizotinib, carbendotinib, and ferritinib. Next, we identified that ZM fusion resulted in hyperactivation of MET and STAT3 signaling. The phase 1 clinical trial of Vbereltinib identified RP2D as 300 mg BID and showed well-tolerated and demonstrated preliminary antitumor activity of Vbereltinib in IDH mutant high-grade glioma. The drug concentration in the CSF increased with the dose, and the CSF concentration in patients treated with 300 mg dosage had reached the corresponding ED90 in ZM-positive U87 cell line-derived xenograft models. This is one of the 2 enrolled patients achieved partial response. After the radiotherapy and 8 cycles of temozolomide, the patient was received for 5 cycles of Vbereltinib treatment. Tumor shrinkage accompanied with symptom relief was observed in this patient after 4 until 16 weeks of Vbereltinib treatment. No radiological progression was detected until the 20th week. This article has been published on Cell. This is a cover we designed with some of the interesting threads in this paper. In Chinese ancient legends, there's a mythical creature named Nian. It often appeared at New Year's Eve and hurt human beings. The only thing that the Nian feared is firecrackers. As time passed, playing firecrackers becomes a Chinese traditional entertainment at every Chinese New Year's Eve. In this cover, the mythical Kuei depicts gliomas with MET alterations, and firecrackers depicts the specific MET inhibitor Vbereltinib. Next, a phase 2 and 3 clinical trial was conducted to assess the efficacy and safety of Vbereltinib therapy in patients with age between 18 to 65 years who had histologically confirmed astrocytoma, IDH mutant WHO grade 4, or GBM with LGG history. Most patients were tested IDH mutant status by immunohistochemistry. Other key inclusion criteria included GM positive or KPS of at least 60, previous treatment with radiotherapy and or temozolomide. The control group was temozolomide dose-dense regimen or cisplatin combined with etoposide. The stratification factor was KPS scores. The primary endpoint was overall survival, and the secondary endpoint was progression-free survival and objective response rate. To achieve power of 80 with the assumption of the median OS for 4 months for the control group, a total sample size of 74 subjects with 70 death events is required. Therefore, an enrollment of 84 subjects was planned, allowing for a 10% dropout. From July 2018 through September 2022, a total of 98 patients screened and 84 patients treated. 43 patients were in Vbereltinib group and 41 patients were in control group. All 84 patients were in ITT analysis populations and 81 patients were in FAS. At a median follow-up of 4.4 months, the two groups were generally balanced with respect to baseline features. The study was initiated prior to the WHO 2021 classification, and in turn, there was a small number of GBM IDH wild type included among the IDH mutant population. As of April 1st, 2023, the average follow-up was 9.9 months in the Vbereltinib group and 6.8 months in the control group. The median OS was 6.31 months in the Vbereltinib group as compared with 3.38 months in the control group. The 3-month improvement in OS with Vbereltinib treatment is both statistical and clinical significant. The HR value was 0.52, indicating a 48% risk of death reduction in Vbereltinib group. Since 1996, the 3 drugs approved by the FDA for the treatment of glioblastoma have improved the overall survival by 1.8, 2.1, and 2.5 months respectively. In our study, Vbereltinib improved 3 months. Similar results was identified in the ITT population. Looking at the secondary endpoint, the median PFS was 1.87 months in the Vbereltinib group as compared with 1.05 months in the control group. PFS was significantly improved in the Vbereltinib group. In the Vbereltinib group, the objective response rate was 9.5%. In the control group, it was 2.6%. The ORR number was not significant, was not statistically significant, but there was a difference. This was one of the partial response patients in this study. A shrinkage in enhanced lesion was observed after 2 cycles treatment of Vbereltinib. In the Vbereltinib group compared to the control group, there was a notable reduction in the risk of mortality observed across various subgroups, including KPS score between 60 and 80, age more than 40 years, female gender, absence of subsequent combined anti-cancer therapy, presence of IDH mutant glioblastoma, a history of 1 prior anti-cancer surgery, and previous use of bevacizumab. Furthermore, now the impact of tumor size at baseline. It was found that patients with a tumor size less than or equal to 3 centimeters in the Vbereltinib group demonstrated a significant improvement in OS compared to the control group. The median OS of patients was 32.5 months in the Vbereltinib group as compared with 4.2 months in the control group. For patients with a tumor size at baseline more than 3 centimeters, there was no significant OS difference between the Vbereltinib and the control group. Vbereltinib also showed favorable safety profile. Most treatment-related adverse events are grade 1 or 2 and recoverable with clinical management. TRAEs of grade 3 or higher severity were observed in 7% in the Vbereltinib group and 12.2% in the control group. No serious TRAEs were reported in the Vbereltinib group and only 2.4% in the control group. Of note, no deaths were attributed to the study treatment in either the Vbereltinib group or the control group. The most commonly observed TRAEs in the Vbereltinib group were rash in 25.6% patients, peripheral edema 14%, increased levels of ALT 11.6%, and vomiting 9.3%. In the control group, the most common TRAEs were vomiting in 29.3% patients, nausea 17.1%, decreased red blood cell count, and constipation 14.6%. In summary, the Fugen study resulted in statistical and clinical improvement in OS and PFS in patients diagnosed with IDH mutant high-grade glioma bearing ZM fusion when compared to the control group. These findings highlight the substantial and meaningful therapeutic benefits of Vbereltinib, supporting its potential as an effective treatment option for a subset of IDH mutant high-grade glioma. The Fugen trial sheds light on the novel therapeutic pathway in the landscape of IDH mutant high-grade glioma. In April 2024, Vbereltinib has received the full approval by NMPA in China for the adult patients with astrocytoma IDH mutant grade 4 with the ZM fusion or glioblastoma with LGG history who have experienced treatment failure in prior therapies. At last, I would like to talk about what we call this trial as Fugen. Fugen is one of the two major bodhisattva, Pu Xian Pusa we call it in Chinese, represents wish and act. In China, people think doctor is like a bodhisattva that gives people a healthy body using the combination of practical spirit and lofty ideals. Clinical work only uses practical spirit to cure patients, but clinical trial combine the practical spirit and lofty ideals to treat more patients. We know we cannot cure every glioma patient, but curing glioma seems like a Noah's Ark. What we want to do is do more researches and do our best to give boarding tickets to more patients who want to board on the Ark. I appreciate our collaborators, including academician Professor Tao Jiang's team that I got my doctoral degree and Professor Jiguang Wang's team that I did the postdoctoral research there. And I appreciate my colleagues and students in my lab and my collaborators. Thank you very much for your listening. Thank you.
Congratulations. What an illuminating talk. Wow, I have so many questions. But perhaps I'll let Dr. Raja start if anyone else has any questions.
So far, there are none. I think we can go ahead. Ben has a...
Well, I so appreciate the fact that you were able to merge Chinese culture as well as art and design and philosophy into this one scientific talk. That was really an appealing part. It was interesting to me, both the analyses as well as design. Maybe to begin with, how did you decide on the 28 days kind of dosing or schema for this drug in terms of analyzing the pharmacokinetics, pharmacodynamics of this drug for the CNS in designing your clinical trial?
Yeah, because most patients, more than 90% of the patients enrolled in the clinical trial is the recurrent glioma. They have the low-grade curves and progress to the high-grade glioma. So we use the continuously treatment using the either temozolomide or the Vbereltinib treatment, because most of the patients were the recurrent tumor.
Got it. So the design was inspired by their prior treatment. Is that right?
Oh, yeah.
Understood. And then I was particularly intrigued by the size analysis, the fact that there's a different outcome for less than 3 centimeter tumors versus greater than 3 centimeter tumors. Conceptually, that makes sense in terms of the size of disease needing to address and thinking about kind of all the extent of resection studies in some way in terms of residual volume of disease, but to apply that to a clinical trial chemotherapeutic regimen is very interesting. I'm not familiar with the literature. Has that type of analysis been done for other glioma directed treatments, even temozolomide or other standard chemotherapeutic regimens?
I didn't catch the question. You mean the Vbereltinib treatment or the temozolomide treatment used for other types of glioma?
Yeah, I was intrigued by the extent of by the prognostic benefit for in your clinical trial for tumors less than 3 centimeter. And usually I think of sizes in relationship to prognosis in terms of extent of resection. But to apply that analysis to a drug treatment was very intriguing to me. Has that type of analysis been used in the past for temozolomide or other drugs? In other words, how does how does your outcomes compare to other forms of treatment for these transformed high-grade gliomas when applying a size gradient?
Okay. Yet the 3 centimeters is decided by the PI's decision that we know the more we dissect the tumor and the long the patient's outcome. And besides the 3 centimeters definition, we also use the median diameters of the tumor size at the baseline. The median diameters is 4.28 centimeters, and we know the longer overall survival time in the patients with less than the median diameters at baseline patients. So it indicates the residue tumors in the patients and the long overall survival the patients did.
Got it. What a nice opportunity for a combined surgical trial to combine cytoreduction through surgery with these clinical trials for recurrent disease. That's a really nice opportunity that you've highlighted there. So I see that Ben also has his hand up.
Yes, first of all, congratulations, Professor Bao and your team. And it's so good that I can see you combine the Chinese, the Buddhism, because I'm also I believe has a belief of the Buddhism as well, and it's so nice to see it in your presentation. And thank you so much. I have some questions for your study, and the first one is about in your experience, like how many percent of the IDH1 mutants and patients are having this FN gene mutation? So how many percent of the patients will have these mutations? The second question is about in your study. I saw that you compared this group with the temozolomide group. And in the patients population of each group, like is the MGMT status also studies so that it will be the similar between two groups, the MGMT status of the two groups, both the study group and the control group. So is there any difference between them?
Yeah, thank you for your questions. And the first question, there was 15% IDH there was 15% secondary glioblastoma patients had the CM fusion, but by the classification 2021, the most secondary glioblastoma patients was defined as the IDH mutant WHO grade 4 astrocytoma. But we didn't check the update frequency of the CM fusion in by the WHO classification 2021. We will check the new frequency by the new update classification. This is the first question, and the second question is sorry, what the second question?
I'm asking about
MGMT promoter. Yeah.
Between the study group and the control group, so it's very similar, or is there any difference between?
We have checked the whole patients with the MGMT methylation status, but we found that there was no correlation between the between the MGMT promoter methylation and the CM fusion. So there's no difference between the two groups of the MGMT promoter methylation.
Okay, that's good. Okay, I see. Thank you so much, and congratulations on your result.
Thank you.
I think we can take the concluding remarks from Professor.
Well, I'm so delighted to see not only of the impact and success of your trial, but also of the overall direction that the Chinese Cancer Genome Atlas and the volume of work that scientists and aspirational surgeons like you have been doing. So congratulations.
Thank you. Thank you so much.
Thank you very much. It was indeed an enlightening session. I'll close this officially now on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both the speakers of today, Dr. Thomas Piriev and Prof. Pao Jiaoxi, as well as Chairs Professor Pablo Gonzalez Lopez and Prof. Linda B, for the time and support for the ACNS webinars. A very special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. And as of now, we have around 320 people who have joined live from all over the world on different channels. Special thanks to my co-host Ben for joining me. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.